Have you ever wondered why one-lung ventilation is so crucial in thoracic surgeries? Let's delve into the reasons. One-lung ventilation, or OLV as it's often called, is paramount in providing a clear and unobstructed surgical field. This is particularly important in thoracic surgeries where precision is key and visibility is everything. In addition, OLV plays a pivotal role in reducing blood loss during these procedures. By isolating the lung being operated on, the risk of bleeding is significantly diminished. Furthermore, OLV helps prevent potential complications such as cross-contamination or spread of disease between the lungs. This is crucial in maintaining the patient's overall lung health and ensuring a smoother recovery post-surgery. In a nutshell, one-lung ventilation is not just a technique, it's an integral part of thoracic surgeries that contributes to the success of the procedure and the patient's health. Understanding one-lung ventilation is the first step in grasping the essential role of the double lumen endotracheal tube. So, how do we achieve one-lung ventilation in practice? Enter the Double Lumen Endotracheal Tube, or DLT. Imagine having a tool that allows you to control each lung independently during ventilation. Well, that's precisely what a Double Lumen Endotracheal Tube, or DLT, does. This remarkable piece of equipment has two distinct channels, or lumens, each catering to a different lung. The beauty of the DLT lies in its design. These two lumens can be controlled independently, allowing for precise management of each lung. This feature becomes particularly useful in situations where one-lung ventilation is needed, such as during thoracic surgeries. The DLT is not just a tool, but a lifeline during these procedures. It's a conduit that provides oxygen, removes carbon dioxide, and allows for the deflation of a lung when needed. Choosing the right DLT is a critical decision that directly impacts the success of one-lung ventilation. Now, how do we choose the right DLT for our patient? Well, there are several factors to consider. First, we look at the patient's size. The size of the DLT should correspond to the patient's height and gender. For example, a taller individual or a male patient will generally require a larger tube. The side of the lung to be operated on is another crucial factor. A left-sided DLT is typically preferred since it fits into the bronchial anatomy more naturally. However, if the surgery is on the left lung, a right-sided DLT may be used. Lastly, we consider the surgeon's preference. Different surgeons may have different preferences based on their experience and the specific procedure. This can influence the choice of DLT. Remember, selecting the right DLT is a crucial step in ensuring a successful one-lung ventilation procedure. With the correct DLT chosen, we're ready for placement. Before we begin, ensure all necessary equipment is available. Prepping for a double lumen endotracheal tube, or DLT procedure, requires a few key tools. Let's walk through them. First and foremost, we need the DLT itself. This tube will enable one-lung ventilation, allowing for a more controlled surgical environment. Next, we'll need a laryngoscope. This handy tool is used to visualize the vocal cords and guide the placement of the DLT. We also require a stylet. The stylet aids in guiding the DLT into the trachea, ensuring accurate placement. Other necessary pieces of equipment include a syringe for inflating the tube's cuffs, a stethoscope to confirm proper placement, and a bronchoscope for direct visualization if necessary. Remember, proper preparation is key to a successful procedure. It's always better to have and not need than to need and not have. With our equipment ready, it's time to place the DLT. Placing the DLT is a delicate process that requires precision. Let's delve into the step-by-step process of placing a left-sided double lumen endotracheal tube, or DLT. To begin, patient positioning is crucial. The patient is usually placed in the supine position. The head should be elevated and slightly extended to open up the airway. The next step involves the selection of the appropriate tube size. This is usually determined by the patient's height and gender. For example, a typical size for adult women is 37 French, while for men it's generally 41 French. Now, onto the actual insertion of the DLT. The tube is inserted into the mouth and guided towards the larynx using a laryngoscope. This is a delicate maneuver that requires steady hands and a keen eye. The tube is then advanced into the trachea. The blue bronchial cuff should disappear beyond the vocal cords, but the black line on the tube should still be visible. This black line indicates that the bronchial lumen is oriented anteriorly, towards the patient's left side. Once the DLT is in the trachea, inflate the tracheal cuff with air, usually about 5 to 6 milliliters. This helps to secure the tube in place and prevent any air leakage. Now it's time for confirmation of placement. This is done by auscultating the chest on both sides while ventilating through each lumen separately. You should hear breath sounds in the left lung when ventilating through the bronchial lumen and in both lungs when ventilating through the tracheal lumen. A fiber optic bronchoscopy is then used to confirm the correct placement of the DLT. The bronchoscope is passed through the tracheal lumen, allowing visualization of the carina, the point where the trachea divides into the left and right bronchi. Once the DLT is confirmed to be in the correct position, it's time to secure it. The tube is usually secured with tape or a commercial securement device. Placement is just the first step. Next comes the application of DLT in one-lung ventilation. Now that we have our DLT in place, let's explore how we use it for one-lung ventilation. The Double Lumen Endotracheal Tube, or DLT, is a vital instrument in achieving one-lung ventilation. This technique is beneficial for procedures requiring optimal exposure and isolation of one lung. To use the DLT for one-lung ventilation, we need to be familiar with its structure. The DLT has 2 lumens, one for each lung. One lumen is longer and extends into the left main bronchus when we use a left-sided DLT. The other, shorter lumen, ends in the trachea. Each lumen has a separate cuff. The tracheal cuff is inflated to secure the DLT in the airway, while the bronchial cuff is inflated to isolate the lungs. The first step in using the DLT for one-lung ventilation is to properly inflate the cuffs. The tracheal cuff should be inflated first to secure the DLT. Next, the bronchial cuff is inflated. This isolates the left lung, allowing for one-lung ventilation of the right lung. It's important to remember that overinflation of the bronchial cuff can cause injury, so inflation should be done carefully, usually under direct vision or with the aid of a fiber optic bronchoscope. Once inflated, the position of the DLT should be confirmed. This can be done by auscultating breath sounds and comparing the right and left lungs. A significant difference in breath sounds may suggest malposition of the DLT. Finally, to achieve one-lung ventilation, the lumen leading to the lung being operated on is clamped, or the corresponding connector on the DLT is closed. This allows the non-operating lung to continue to ventilate, while the operating lung is isolated. Understanding how to use the DLT for one-lung ventilation is a crucial skill for anesthesiologists. It allows for safer, more effective procedures and can significantly improve patient outcomes. But how does the non-operating lung deflate? Let's find out. The deflation of the non-operating lung is a crucial part of one-lung ventilation. It's a delicate dance of pressure difference and precision that allows us to perform surgeries that would otherwise be impossible. But how exactly does this deflation occur, and how does the Double Lumen Endotracheal Tube, or DLT, aid in this process? Well, let's dive right in. When we're dealing with one-lung ventilation, the non-operating lung naturally starts to deflate due to the pressure difference. The one lung that's being ventilated is under positive pressure, meaning it's being actively inflated. On the other hand, the non-operating lung is under negative pressure. This negative pressure creates a vacuum of sorts that pulls the air out of the non-operating lung, causing it to deflate. Now, you might be wondering, where does the DLT come into play? That's a great question. The DLT plays a vital role in this process. Remember, the DLT has 2 separate lumens, one for each lung. When we're performing one-lung ventilation, we close off the lumen leading to the non-operating lung. This closure prevents any additional air from entering, which aids in the deflation process. Additionally, the DLT also allows us to actively deflate the non-operating lung if necessary. This can be done by attaching a syringe to the lumen leading to the non-operating lung and gently drawing out the remaining air. This active deflation can be particularly useful in situations where the non-operating lung hasn't fully deflated on its own. But remember, deflating a lung, whether naturally or actively, is a delicate process that requires a keen understanding of the anatomy and physiology of the lungs, as well as a steady hand and a sharp mind. It's not something to be taken lightly, but with practice and precision, it's a technique that can open up a world of possibilities in thoracic surgery. And there you have it, a comprehensive guide to the use of DLT in one-lung ventilation. Remember, practice and precision are key. Even with the best intentions and the steadiest of hands, DLT malpositioning can occur. This often unforeseen complication can lead to a myriad of problems, from inadequate ventilation to injury. Let's take a closer look at some common errors associated with DLT malpositioning. First up is the incorrect tube size. It's crucial to choose the correct size of DLT for the patient. An oversized tube can lead to tracheal injury, while an undersized one can result in inadequate ventilation. This is why choosing the right DLT, as we discussed in Scene 3, is so important. The second common error is incorrect placement of the tube. The DLT has to be placed in such a way that it allows for ventilation of the correct lung. If placed incorrectly, we might end up ventilating the wrong lung, which can have serious consequences. The third and final common error we'll discuss is the displacement of the tube during patient movement or surgical manipulation. Even slight shifts in the patient's position or during surgical procedure can displace the DLT, leading to inadequate ventilation or even injury. Being aware of these common DLT malpositioning errors is the first step towards preventing them. It's essential to always double-check the DLT's position, size, and placement before proceeding with one-lung ventilation. By doing so, we can ensure successful one-lung ventilation and minimize the risk of complications. Next, we'll move on to the final scene of our video. Stay tuned.